Welcome to Ask the Experts, presented by Salinas Valley Memorial Healthcare System. My name is Christiana Kearns, and I am the Senior Administrative Director of Cardiovascular, Pulmonary, Sleep, Nutrition, and Rehab Services at Salinas Valley Memorial Hospital. This month we are celebrating Heart Month, and this Ask the Experts presentation we are going to be focusing on the MitraClip. The MitraClip is a minimally invasive procedure that fixes a leaking heart valve. This is a condition known as mitral regurgitation. Salinas Valley Memorial Hospital is currently the only hospital in the region performing this procedure. Before I go any further, let me introduce you to our panel this evening. Dr. Patrik Zetterlund is an interventional cardiologist at Salinas Valley Memorial Hospital, where he also serves as Medical Director of Cardiovascular Research and is also the Medical Director of the Cardiac Cath Lab. Dr. Zetterlund joined Salinas Valley Memorial's medical staff and established Central Coast Cardiology in 1994. Joining him is Dr. Kanae Mukai. Dr. Mukai is a cardiologist who has completed several subspecialties focusing on cardiac CT, MRI, nuclear cardiology, and echocardiography. Dr. Zetterlund and Dr. Mukai perform the MitraClip procedures at Salinas Valley Memorial with the assistance of several other team members. Also joining us today is Ann Timberlake. Ann is a registered nurse and the MitraClip program coordinator. Thank you all for being here today. In today's presentation, Dr. Zetterlund will be focusing on the MitraClip procedure, how it works, how it is performed, and who is a candidate for it. Dr. Mukai will focus on imaging in order to perform this minimally invasive procedure, and Ann will focus on the coordination process and post-care. Dr. Zetterlund, we will begin with you. Tell us a little bit about what mitral regurgitation is and what symptoms a patient might experience and how dangerous it is to live with this condition.
Well, first of all, the mitral valve is the inflow valve into the main chamber of the left ventricle. And normally this valve acts as a gate to allow the blood into the heart to then be pumped forward into your body. So what mitral regurgitation is, as I said, it regurgitates. It starts leaking back into the lungs. So what then happens is that as blood is trying to go forward and go into the body, it's actually damming up in your lungs, and you get shortness of breath and you get heart failure. A lot of people have mitral regurgitation. It's mild and we can treat it with medications, and you can do well for many, many years and have minimal symptoms. But by and large, these symptoms get worse because it's a progressive disease, and ultimately your heart will fail and you'll come to a situation where you'll be faced with intractable heart failure. You literally can't do anything. You're now faced with surgery, or in our case now, we can offer the MitraClip procedure, which is a very minimally invasive way to repair the valve to prevent it from leaking backwards, so to speak, but rather forward blood flow so you can alleviate the symptoms.
Excellent. Can you tell us a little bit more about the MitraClip and how this procedure is done?
We have a brief computer animation that will kind of illustrate what actually the procedure is all about. A three-dimensional computer image of the heart, and you can see what we call the right atrium, the left ventricle. So there's the mitral valve. That is the valve that I told you earlier about, that is supposed to let the blood only into the ventricle but not flowing backwards. And you see the red animated blood flowing appropriately from the left atrium down into the ventricle. So that's a happy looking mitral valve. So now you can see the blood going backwards. That is, that when the ventricle squeezes, the blood is now flowing up. And that's not abnormal because the blood is then going to be damming up into your lungs. And the reason you get short of breath is because the pressure in the lungs increases because of the blood not going forward but going backwards. So here is an animation of the actual MitraClip. And here is the device that actually sits on the table on top of the patient on the stand. And you see all those knobs and controls there. And it's quite a challenge actually to keep track of all that. So easily we go into the vein and we go up from the groin and we go to the right side of the heart, and we actually poke a hole in the heart from the right side of the heart into the left side, into the left atrium. And you can see an animation of this little sharp thing that is actually a needle, and you see the little tube come in. And over that tube we will actually then advance the actual MitraClip device. So we have to come in a perfect position above the valve. And at this point I am completely under the command of Dr. Mukai, because I am led completely by the fantastic technology of transesophageal echocardiography in this case. So here we are actually now angulating, and we open up the clip and we position it, and we would then carefully bring it across the valve. And we have to be really careful when we go across the valve because you see all these little parachute lines down there. You don't want to get tangled up in those because you will not ever be able to grab the valve. But in his case, you see an animation where we bring it back up, we pull the valve together and hold it, and the clip is pinched together. And then we take pictures, and we can still reposition if we want to. We have not determined yet that we're happy. But once we see under the transesophageal echocardiogram again that we have the result we want, we then will permanently let go of this device. But in this case, that shows the illustration that we are kind of going back and forth until we're happy. But here we let go, and there's the clip. And this clip will then stay in there forever. They will fibrose, it will become part of your heart, and it won't go anywhere. And here's a little bit of an illustration of fibrosis occurring over time. And it becomes part of your valve.
Thank you, Dr. Zetterlund. And Dr. Mukai, during this procedure, you focus on the imaging portion. Can you tell us a little bit about that?
Yes. Christy, so as you know, mitral regurgitation, as Dr. Zetterlund mentioned, there's different forms and types of mitral regurgitation. It really comes down to what the valve anatomy looks like. And that's where the imaging really helps because as you do and prepare for the MitraClip evaluation, we do what we call a transesophageal echo and take basic baseline pictures to see what the size and anatomy of the clips should be if we were to go ahead and fix them with the MitraClip procedure. So it's a very important part of the MitraClip procedure, pre-procedural setup as well as the actual procedure. Inside the procedure, we also have the imaging, guiding Dr. Zetterlund, essentially sort of being the eyes for Dr. Zetterlund and sort of guiding him where to go and where to clip. As you mentioned, it's a fairly intricate dance, and it's really important to have a very clear communication between the imaging person and also the interventionalist. This is just a short couple of slides to go over the imaging guidance for MitraClip. So as Dr. Zetterlund mentioned, it is a fairly intricate procedure, and you have to place the clip right underneath the mitral valve and eventually release it. And essentially the reason why imaging is so important is because you really have to know the type of mitral regurgitation. And that's something that's really best shown with a transesophageal echo. And these are some examples that you see. So on the far left is a normal valve. Right next to it is a degenerative mitral valve with a prolapsing valve, so you're typically born with this. The third one to the right, from the left, is the degenerative flail, and you have functional mitral regurg. And these types of anatomy is really important to understand before you go in and get sized for the MitraClip procedure. And I'm just showing you some examples of cases that we've done so far. So these are on the left side are the pre-images, and on the right side are the post-images. And I'm just showing you some examples. So on the far left here, that's a pre, and you see that large jet of mitral regurgitation coming back. You have a 3D of what the mitral valve looks like. And then on the post, you can see that the jet is significantly less. And also the MitraClip is seen here. It looks like it's kind of blinking its eyes, so to speak, but it's a nice shot of the 3D of the mitral valve with the clip in action. Similarly, there's an example on case 2. On the far left here on the case 2, you can see that the mitral regurgitation is shown on the pre-images on the far left, and the baseline images on the bottom here on the 3D. And on the far right is shown after the clip is deployed. And you can also see this on 3D as well. And the big thing is knowing the type of clip. So you can see on the far right, the types of MitraClips that we are placing is listed. And also, pre-mitral regurgitation, 4+ is severe, and it usually brings it down to trace or 1+. This is a third example here. Similarly on the far left and on the right, you can see the clip, different type of anatomy and different type of clip here. And lastly, case 4, you can see the significantly large jet on the far left, and on the far right is actually significantly improved. The MitraClip sizes are very small, as you can see here, and it's really literally the size of a dime. And these are very small clips that you have to put into the heart, but really knowing where the images are, knowing where the clip is at all times before the procedure and also during the procedure is very important, so that way we can actually be successful in our cases, which we have been.
Dr. Mukai, great presentation. I'm looking back at those pictures and realize what a wonderful job we all did together in this amazing team effort.
In a few minutes, we'll come back to Dr. Zetterlund and Dr. Mukai, who will be demonstrating how they perform the MitraClip procedure. In the meantime, Anne, you are the MitraClip program coordinator. Can you please walk us through the process that a patient goes through and if a referral is needed to get into the program?
Well, I help guide patients through the workup process because it does require some testing and consultations with the primary physicians on our MitraClip team. So I do patient education, also teaching with the family. Usually patients are referred by either their cardiologist or their primary care physician because they're having symptoms such as shortness of breath. So first, a regular echocardiogram is done, and if that shows that they have significant mitral regurgitation, then they're scheduled for this transesophageal echocardiogram that Dr. Mukai was describing. And that is very specific and takes measurements to determine if it's possible to repair that leaking valve with a MitraClip. If it is, then they'll have a consultation with Dr. Zetterlund, and our team of physicians will review their case and determine if the patient is ready to schedule. So I help get them scheduled for the procedure, do the teaching with the patient and the family, and then after the procedure, I actually track their progress for a year.
So, Anne, since the MitraClip is part of our structural heart program, can you tell us a little more information about the other minimally invasive procedures that make up our structural heart program?
Yes, we offer TAVR, which is the transcatheter aortic valve replacement, and this is a procedure that can replace a severely narrowed aortic valve using a catheter instead of open heart surgery. And that does require a workup process, and then our team of physicians reviews the case to determine if the patient is a candidate for the TAVR. The other procedure we offer is called the Watchman, and this is for patients who have the irregular heart rhythm called atrial fibrillation. This rhythm can put them at higher risk for stroke due to a blood clot forming in a little pocket inside the heart. So they're usually on a blood thinner to help prevent that. However, there are many people who can't tolerate taking blood thinners due to things like bleeding or a risk of falling. And so for those patients, this Watchman device can be implanted inside that pocket in the heart using a catheter, and it blocks blood clots from forming there. So most patients can stop taking blood thinners about 6 weeks after the Watchman procedure.
And who could people contact should they want more information about the MitraClip, TAVR, or Watchman procedure?
Well, they're welcome to contact me. We'll be showing a slide with my phone number and my email, and then I can give them more information, help them with the referral process, and help them get scheduled for a consultation.
And now Dr. Zetterlund and Dr. Mukai are ready to demonstrate how the MitraClip procedure is performed in our cardiac cath lab with the assistance of Chris Perrone, who is our territory manager with Abbott.
Great to see you again, Chris. You're my wingman when we do these cases.
Absolutely, Dr. Zetterlund.
So, Kanae, I want you to tell us a little bit about this beautiful little clip you have there.
Well, I think the artistic rendition of MitraClip would be if you imagine that your valve is like this, and you've got the anterior and posterior leaflets right here, then really simplistically speaking, it's actually just literally putting a clip on your mitral valve, and that's how it works. And we're going to show you some examples that's a bit more technical, but the concept is there. This is how it works. You want to, maybe Chris, you can show us how we can grab this with the MitraClip?
Absolutely. So the clip itself is made of titanium, chromium. It's got a polyester mesh on the outside of it, which allows tissue to ingrowth into it. As Dr. Zetterlund says, it essentially will eventually become part of your heart. It is positioned over the mitral valve very carefully. The arms are opened up to allow us to orient where we want the clip to be. And also, Dr. Mukai has identified on echo where the main anatomical anomaly is, or where the main regurgitant jet is located. So Dr. Zetterlund positions the clip over that location. The arms are opened so we can get a good orientation so that the clip is perpendicular to the valve itself. The arms are then closed slightly, and it is carefully lowered down into the left ventricle. The arms are then opened back up, and it is slowly pulled back up towards the left atrium, Once the leaflets are lying flat on top of the arms, and we can visualize that on echo, that they're lying flat, we have good insertion, we then lower the grippers on the top portion. So now we are holding the leaflet on both the bottom and the top of the mitral valve, and then the arms are drawn together and pinching the leaflets together. And in this simple way, we are allowing the leaflets to come together and reduce MR.
Thanks, Chris.
Absolutely.
And we recognize that this is an actual real clip that is as a model here. See how small it is? It's probably about 10 to 12 millimeters, right?
Correct.
And actually, that's why we picked them, because we have 4 different clips, and there's a bit of an art how to determine which kind of a clip we're going to use depending on the location of the leaking. Most of them are in the middle of the leaflet, but sometimes when we get out on one side, we perhaps have to use a somewhat different size clip, and sometimes we have to put 2 of them in. But it's remarkable how this small device can make such a difference.
Yes, that's correct. There are 4 different widths, or 4 different clips. They are 2 different widths and 2 different lengths. And based off of what we've decided in Dr. Mukai's pre-screening, and we huddle up in the beginning, we decide which clip would be appropriate for this specific patient. And sometimes we do need to put in a second clip.
Now, the clips have been around for quite some time, right, Chris? How many years has it been?
They've been, so this device, this generation is fairly new, but they've been on the market for several years now, for nearly a decade.
So the technology is pretty well established.
It's pretty well established.
But it has gotten much more forgiving and easier to place
Yeah,
comparison to the first generation clips, which I first saw. And I must frankly say I had some doubts, and then when I saw the 4th generation coming, I said, this is it, we got to do this.
Yeah, they're constantly evolving and developing and making the delivery system easier, giving more options on clips. The G4, which is what we're currently using, has introduced multiple clips, as what we were mentioning before, different lengths, different widths, and they continue to develop, making the delivery system more forgiving, as you were saying.
Well, thank you for that part, because that's a challenging part. Tell me, how many steps is it to set up the delivery system?
In prep, it's a pretty long list. Yes. We are ensuring before the device or the system is even inserted into the body, we do a series of steps, making sure that everything is working appropriately. So it's dozens of steps prior to even entering the body.
And I have to admit that I am totally blind unless I had Dr. Mukai giving me the pictures. And how this is a very imaging-driven procedure. There is really minimal X-ray. People think in a cath lab that, oh, it's all X-ray and dye. There is none of that in this procedure at all.
It is probably 90% echo and 10% fluoroscopy. Yeah, and the images that Dr. Mukai provides are critical to identifying where the pathology or the jet is and allowing you to carefully navigate down and get above the pathology and then below it and then come up underneath it and pull the leaflets together.
But I have to say, I think the teamwork is really important. So we have to all be able to communicate together on the real time, essentially. And that's what I think what really makes us special. The team is very special that way.
Absolutely. Good communication within the case is essential to a good outcome.
Exactly. And having been on the genuine cases, I can tell you this is so much more advanced, and I'm really appreciating the G4 device.
Absolutely.
So anyways, after the patient wakes up under very light anesthesia and they're up and about and have lunch and go home the next day, what can they look forward to in terms of mortality and morbidity? What do you think this does for the patient?
Well, the data on the COAP data was a landmark trial which really expanded the patients who could benefit from from MitraClip. What it compared was traditional guideline-directed medical therapy, which is pharmaceuticals, versus guideline-directed medical therapy with the addition of MitraClip. And what they found after 3 years is that MitraClip, when combined with guideline-directed medical therapy, had reduced heart failure hospitalizations by 50%. It reduced all-cause mortality by 33%. Patients reported a 2.5 times greater quality of life. It also proved to be very effective at reducing MR and a very safe medical procedure. So the data is pretty clear on the benefits of MitraClip. Patients tend to report back that they are feeling immediately better. Sometimes it takes a little while for the heart to remodel, but I think that patients in the long run will benefit from MitraClip.
Well, I can certainly tell you from the number of patients we have done, when I see them a week or two later, they feel dramatically better.
That's very encouraging news. That's what we want to hear. Yeah. A testimonial back from the patients is really just, it just makes you believe in this therapy, and we want to try to find as many patients who can benefit from it.
Yeah, I have a lady, I think we were just now doing yard work now. She never gotten a chance to do yard work, and now with the clip she can do it, which is great.
That's right.
That's incredible. Those are the stories we love to hear.
Well, thanks for stopping by.
Yeah, thank
Absolutely.
Appreciate it.
Thanks
we'll
for
see
having
you in
me
the
down.
cath lab soon.
Yeah, absolutely.
Thank you.
Thank you.
Just like the MitraClip, the Watchman and the TAVRs are performed in our cardiac cath lab under light anesthesia, and patients are up and walking just in a few hours later and can go home the next day. So far, we have performed 111 TAVR procedures, 97 Watchman procedures, and currently at 4 MitraClip procedures with many more on the books about to happen soon. Our cardiac cath lab is state-of-the-art facility that is also can be converted into an operating room should that need to happen. We have the best of the best. Right now, you're looking at some photos of our fantastic cath lab staff. They are an amazing and incredibly talented, dedicated group of healthcare professionals. We thank them for all they do for our patients. Before we wrap up, we should discuss something that is very important. During the past 2 years of this pandemic, many people have delayed cardiac care, and unfortunately, for many people, the consequences have been devastating. Dr. Zetterlund, what would you like to tell people who are considering delaying their care?
Don't. See your doctor. And we can still work through the pandemic with all the COVID and the impact it has on the hospital to still provide this structured heart procedures. And the program has essentially been continued throughout this COVID pandemic. So there's no reason to delay your care. Get in touch with your doctor, get in touch with your cardiologist, and then come and see us if we can help you.
Dr. Mukai, how about you?
I think it's important to, as Dr. Zetterlund mentioned, just make sure that you have a contact with your doctor. Give us a call if there's any interest in getting evaluated. We can certainly make that happen. Thank you.
Thank you. And Anne, anything to add?
We have a wonderful team, and our hospital is taking good care of the patients who need care for COVID, but there is no reason to delay getting your care. And if you have an emergency, come into the emergency room so you can be evaluated immediately.
Thank you. Great advice. Again, if you'd like to learn more about the MitraClip, the Watchman, or the TAVR minimally invasive procedures, please contact our program coordinator, Ann Timberlake. You can reach Ann by calling 831-759-1992 or by emailing her at atimberlake@svmh.com. Both Dr. Zetterlund and Dr. Mukai see patients at Salinas Valley Medical Clinic, Central Coast Cardiology in Salinas and in Monterey. In Salinas, Central Coast Cardiology is located at 230 San Jose Street, and in Monterey, Central Coast Cardiology is located at 5 Lower Ragsdale in Ryan Ranch. The phone number for both locations is 831-758-2100. Dr. Zetterlund, Dr. Mukai, and Ann, thank you so much for being here today and for providing such valuable information about the MitraClip procedure. We appreciate your time, your expertise, and your dedication to healthcare and to our community. And for you at home, thank you for watching. I'm Christiana Kearns, and as always, love your heart, because we certainly do.